right. Hello, everybody, and welcome to our JHM Wiki virtual toolkit series. With the goal here is to engage and imply, and we are Ryan White HIV/AIDS Part D funded program. Next slide, Marinas. For those of you who don't know me, I'm Allison Agu. I'm a professor of adult and peds ID and the program director for this program. And really, I think this is probably my favorite program. Don't tell anybody else, they might be here. But the JHM Wiki collaboration is a collaboration of 5 programs, distinguished programs, including us at the Pediatric Adolescent HIV/AIDS program and several of our partners that you see here, including the Johns Hopkins Women's Health Program, which Jean Keller is our distinguished guest today. Our vision really is to achieve a more coordinated response to HIV, even more important now than ever, by trying to establish mutually beneficial relationships that increase the quality of care that we provide to women, infant, children, and youth wiki populations as a community. And the goal is not to reinvent the wheel, but to build upon the existing structures we have and systems and to synergize and multiply what we're doing. And this is our signature series to engage and amplify. So see something, say something. If you have something that's amazing where you are, we'd like to hear from you. We'd like to highlight you as well. And kudos to our funders, HRSA, get there. But today can we make sure we mute, please, if we're not talking? Today, I'm so excited to have Jean Keller. Jean, that's a fabulous picture of Jean. It's over 30 years.
Oh, I hate that picture.
Beautiful. A colleague and friend, Jean Keller, has over 30 years of experience in the women's healthcare and is the co-director of the Johns Hopkins HIV Women's Health Program. Jean provides reproductive health care to women in adult HIV clinic at the Bartlett Specialty Service. And in addition to HIV, she has a special interest in STIs or sexually transmitted infections. Jean began her career just last year at Planned Parenthood of Maryland, working primarily with disenfranchised women from Baltimore City. And then after being at Planned Parenthood for 3 years, she came to Johns Hopkins Division of Infectious Diseases during the early years of the HIV epidemic to provide care for patients who were living with HIV. And while working in that clinic, she saw a growing number of women with HIV and a growing interest and joined Jean Anderson, another of the Jeans, and developed the women's HIV Women's Health Program to respond to women's unique needs. Jean received her bachelor's in biology at Malloy College in New York. She has lectured locally, nationally, and internationally on HIV, HPV, and other STIs. She chairs the Johns Hopkins Ryan White HIV Collaborative Quality Improvement Committee and is involved with many quality improvement initiatives in the city and state and beyond. It is my pleasure to have Jean talk to us about an amazing project she's doing, but also just about intimate partner violence and how to respond within clinical services. Jean, please take it away.
Thank you. What a wonderful introduction. And thank you for having me. So I was asked to give this talk about implementing intimate partner violence screening and response into clinical services as part of Domestic Violence Awareness Month. And this, working with Joyce Jones in the Bartlett Clinic, and for those of you who are unaware, we have a multi-service clinic called the Bartlett Clinic that provides services to over 3,000 patients. And we have collaborations with PEDS, with Allison and her group, and also with Joyce Jones. And she and I and some others really took on this sort of journey of not only making sure that we implement screening, but what do we do when somebody screens positive and how would we help our clients, our patients? So just a quick overview. This is a really broad topic, so I'm trying to just get to key points today. But what are the key components of creating a trauma-informed culture? How do you implement routine screening for IPV as part of that? And understand how to implement, most importantly and most difficult is how do you implement a workflow for those who screen positive? And then lastly, and very importantly, supporting and engaging clinic staff who provide that trauma-informed care. So just a couple of simple definitions. Trauma-informed care is really a broad-based term that refers to a strength-based framework that recognizes the impact of trauma and integrates knowledge into service delivery. IPV, or intimate partner violence, is a subset of that and is defined as the occurrence of or threat of physical, verbal, sexual, emotional, or psychological abuse by a current or former intimate partner. So there are five guiding principles of trauma-informed care. First and foremost is safety, safety within our clinic walls, safety concerns of our patients when they come to us. Giving our patients choice, making them a partner in this journey so that they are empowered, which is the last um, guiding principle here, so that they are informed and aware and making good choices. Collaboration, I cannot tell you how important this is. We do not have to do this alone. I know we're all from very different institutions. We have a very large institution, so we're often lucky that we can find partners within our institution, but partners outside of our institution. There are, in your community, who in your community does this work, who can help with this work, and who can you refer to out in that community when you have somebody who needs services. Building trust is incredibly important, and we'll talk about that a little bit more of how one builds trust with patients when they reveal this very, very intimate experience with you, and how difficult that is, and they really need to feel that they can trust us. And again, empowerment, the importance of empowerment, and how we can help our women, men, youth, whatever population you're working with, feel empowered, because that's been taken away from them. So, just a little background on how prevalent this is. About 1 in 5 and 1 in 7 men have reported experiencing severe physical violence from an intimate partner in their lifetime. 1 in 5 women and 1 in 12 men have experienced contact sexual violence by an intimate partner, and 10% of women and 2% of men have reported having been stalked by an intimate partner. In addition, over 43 million women and 38 million men have experienced psychological aggression by an intimate partner. That's a huge number, which actually kind of also surprised me. So it gives you an idea of the breadth of this. Over half of women who are murdered in this country are killed by a current or former male intimate partner. So, for those of us, we work in HIV, and there really is a synergy between HIV and IPV, and that in this particular study done in 2019, they reported that 55% of women and 20% of men living with HIV experienced IPV. 24% of the women experienced abuse by their partner after disclosing the status. And for those of us who have worked in HIV for a very long time, particularly in the, probably still happening now, but we've heard these stories and what happened, and how not only people were treated not just by the public in general, but particularly early on, but their partners, and how frightening that was for them. Know that IPV increases the risk of HIV acquisition. And then those who are HIV infected, those who experience IPV, really it interferes with both their engagement and adherence to care. So again, talking about more about the relationship between IPV and HIV, there are potential confounders in green here, and also mediators between IPV and HIV. And some of the confounders are early sexual debut, multiple partners, propensity for concurrent partners, or partners with propensity for concurrence, all leading to exposure to IPV. And then potential mediators to HIV is the reduced condom use. You take away somebody's power, they don't have the power to use condoms, right? We also see this in pregnancy, women who get pregnant because they don't have the ability to use birth control. Higher relationship dissolution, lower entry into marriage, increase in secondary partners, and a lower ART effectiveness. All of this is part of this relationship between IPV and HIV. So this journey for us started when Dr. Anderson and Allison were part of a study called SAVA. which stands for Substance Abuse, Violence, and HIV/AIDS. And this synergy was conceptualized as early as 1994 as sorry, as closely intertwined and mutually enhancing epidemics that are fueled by social and economic inequities. Um, HIV, substance abuse, and violence each contribute independently to the collective health burden of the women we serve, but they also act synergistically to negatively impact health outcomes. And this co-occurrence is called the SAVA syndemic. Now, not to forget about depression, that there is also a relationship between IPV and depression. And we know that women who are depressed, 31% of them will experience physical violence by an intimate partner during their lifetime. 47% will experience psychological aggression. And a number of these women, or a large majority of them, really rely on public assistance and have been who are also victims of domestic violence as adults. This is a huge cost to our healthcare system every year. And also keep in mind that 7% of US adults have had at least one major depression episode in the past year, and a lifetime prevalence that's much higher. So depression is a huge problem in our population as well. So where do we go from there? So what are the components of trauma and violence informed care? So there's clinic-based and community-based. So for those of us in the healthcare system, what does our clinical based components include? Universal education. I'm going to talk about that more because I think that's really important. How do we help people disclose IPV? And then how do we counsel and safely plan and provide warm referrals for those who are ready to do so? And that really is where we tie into the community-based impact of this. So we know that we want to find places in our community where there's counseling and advocacy available, in addition to those things that they're going to need when they try to escape an abusive relationship and get out on their own. Housing, food security, and social support, all of those things that sometimes keep particularly women trapped in bad relationships. So the abuser really uses their power as control, and it's the IPV power and control wheel that we see here, and it includes physical violence, physical and sexual and emotional violence, and impacting all of these things in their life, and using coercion and threats, intimidation, economic abuse. This is one that I've seen often in my career, is women who say, I can't afford to leave. I depend on them for rent. I depend on them to my apartment. I have children, and which is another factor that the abuser will use, is using the children. How are you going to take care of your kids if you don't have me? And keeping them isolated and using emotional abuse. So these are all part of that control wheel. So how do we then go to the next steps and create a trauma-informed culture? First and foremost, training the staff, even for those who are not going to be directly involved with screening and helping our patients, making them aware that this is a part of the clinic culture, that they understand what trauma-informed care is, and then implementing a routine screening for trauma and trauma-related symptoms. And I'll talk more about screening in a little bit. But for us, the real goal was, how do we go from screening to then creating a workflow for those who screen positive? And this is tricky. So, how do we help? All of us felt, we first went on this journey, we all felt a little inadequate about this. It's like, what do we do? We're not trained. What if we make things worse? We open this door and is it going to trigger our patients? Are they going to, we're going to make things worse? And the answer is no, you can't make things worse, but you can do this in a way if you're trained appropriately, that really helps the patient, even if they're not ready to get started, really helps them understand that you're there for them. And then having those things in place for them when they are ready. And always, always, always making sure that you have support for staff who are doing this work, because it can make trigger something from their past or in their lifetime. And it can also be it's a difficult issue to work with patients with. It's sad and it's overwhelming. So how do you get started? So these are sort of the key things that I and my group has learned on how you do this and how you really go from, just a screening tool to really implementing change in your clinics to help the process through. So first and foremost is establish a team and set up regular meetings and really finding a time that people can attend and getting a group together that will carve out that time. And I can tell you for our team, we've been doing this now for over 2 years. We have a large clinic, so it's a little bit more complicated than for most people, but we've been doing this for 2 years. We meet pretty much weekly, and have you get started and you see it just opens these doors, and you just have to, the floodgates open, and there's so much you have to learn and understand. It doesn't have to be quite 2 years, so which is hopefully guidance will help you. So who should be part of your team? For us, it was a provider, a nurse, medical case management, social worker, patient navigators, and then assigning roles for those folks. Who's going to take the lead? For us, it was Dr. Jones, Dr. Joyce Jones, who really took on the lead. She also happened to be the note taker because she's very good at that. When she's talking, she can take notes. And while we're meeting, we have this ongoing meetings minutes that have been ongoing for just, so that we see our progress. And when we go back, we can see, the next meeting, what did we get accomplished? What do we still need to do? What worked, what didn't work? Next, identify the goals and objectives for your clinic. It's going to be different for every healthcare site. So what we do might not necessarily be right for your clinic. We have a very large clinic, so it can be a little bit difficult to navigate when you have 3,000 patients that have to be screened. How do we go about doing that? Which may be very different than a smaller clinic or a health department. Just then decide on a validated screening tool that works for your clinic. And I say validated because you really want a screening tool that has been validated and works. Next, use already available resources. You don't have to reinvent the wheel, right? There are so many resources out there that you can dig into, and I'm going to talk about some of those and how you access them later on. Develop a protocol, develop a workflow, so that everybody understands how in your clinic how this works, and something that they can reference when things occur. Establish a timeline.
Stop.
I'm sorry. Establish a timeline. So this really helps keep you on target. Of course, our timeline, you say you're going to do something by December, and then it winds up being January, February. That's okay, because at least you're reviewing the timeline, and you weren't quite able to accomplish things the way you thought you could, but it's still in your timeline, and you can just adjust it as you go on. And then research the trainings that are available. There are so many trainings out there that can help you to do this that we've already done, and I can't tell you how helpful it's been in really helping us to hone in our skills and to do things in a way that have been validated. And then finally, research who in your community you have as referral resources and reach out to them. And really, so when you do a warm handoff, you know who you're sending your clients to. So the screenings that we do currently include depression, anxiety, substance use disorder, including alcohol, and IPV. I start IPV because to me that's the most difficult. So I think all of us know what to do when we screen like positive for depression or somebody screens for anxiety or substance use disorder. You have your, either in your own institution or in your community, you know who to refer to. IPV is a little bit more difficult. A very personal topic for a lot of patients. It opens up a lot of fear in our clients. And so really doing this in a way that feels safe for them, and then making sure that we have our process in order. So this for us was why we took this on, because to us this was the most difficult thing to do. Is once we have somebody who screens positive, how do we help our clients now? You don't want to find, what you don't want to do is screen somebody for IPV and then have nothing to offer, because that's just, I think that's kind of traumatizing. So hopefully this talk will help you a little bit today. So when we first looked at our IPV screen, which is part of our EMR, which is part of our medical record, there was one question. We thought, you know what, this is not adequate. So we went back to our people who develop our EMR, and which is called Epic, and we asked them if we can expand it. And these are the 4 questions that we think really are helpful. Within the last year, have you been afraid of your partner or ex-partner? Within the last year, have you been humiliated or emotionally abused in other ways by your partner or ex-partner? Within the last year, have you been kicked, hit, slapped, or otherwise physically hurt by your partner or ex-partner? And within the last year, have you been raped or forced to have any kind of sexual activity by your partner or ex-partner? So that might not be the right screening for your institution or your clinic, but these are some of the things you can consider, and of some of the other considerations for screening. We talked about safety earlier on. It's really important that when you screen for IPV, probably all screening, but particularly for IPV, that it's private and confidential and a safe and supportive setting. If and this, informed consent will also depend on, you want to prevent re-traumatization. So informed consent, depending on locally what your laws are, because there are times when we have to report things and patients need to know that up front before and give them the choice of whether or not they want to answer. What is the effectiveness of your screening? Make sure that it's sensitive, specific, and it's validated. Time to complete the screen. You want it, screenings should be simple. They should be something that we can do easily in our clinic. We don't want to be overwhelmed by the screen, because then it won't be done. Other questions, and this is things we talked about a lot. How often do we screen? Who should we screen? Is the screening available in your electronic medical record? And if not, can you insert that into your record? Um, what are your resources and appropriate referrals? And again, this is what we spend lots of time on, is researching what we have available to us and how we are going to implement that when somebody screens positive, and particularly if there's an emergency. And then knowing your mandatory reporting issues, and that goes back to informed consent, because and laws will change from state to state. So some state laws are all each state has different laws about this, and really understanding what your particular state law is. So, what are some of the barriers that you find for screening? So, this was actually barriers that were identified by providers, just to get an idea of why people aren't screening for IPV. So, for the providers, it was a lack of awareness of the problem and its prevalence. And we know now that it's very prevalent. Discomfort with the topic. These are difficult questions to ask somebody. These are difficult questions to talk about. So the person who screens needs to be comfortable so they can make their client comfortable. The tendency to blame the survivor. I'm hoping this doesn't happen anywhere. I hope that we all have some empathy about this and don't blame the survivor. Lack of training, which goes back to the importance of really getting trained appropriately so that we are doing things, we understand what we're doing and how this impacts our clients. Inadequate resources or lack of knowledge of available resources. So, let's do our homework. Let's make sure that we know what we have available for us. Um, Not knowing how to respond to a positive screen. And this is what got us started. It's like, oh my God, we need to have something in place. We can't screen and not have something in place. So we need to learn how to do this. Lack of time. I mean, we have busy practices, right? Who's going to screen? Who has the time to screen? How do we make it as simple as possible and so that it's effective in our particular clinic situation? Lack of privacy to screen. You have to have privacy to do the screening. You can't be asking this in an open environment. Fear of offending the patients. You're not going to offend the patients if this is done with in an empathetic way. They will, even if they're not ready to answer, they know that you're there for them. And perception for at least the clinician that it might not be the clinician's role. And that's going to, who does the screening is going to vary from clinic to clinic and depending on the practice. So, how often to screen? This was another question that came up a lot. So, unfortunately, there's no evidence-based guidelines for this on what optimal screening intervals are. But we now know that with the prevalence and incidence of these problems in the setting of HIV are, so you may want to consider, what works in your clinic, screening at regular intervals. Would that be at the annual exam? Whoops, so sorry. At the annual exam. Should it be at every visit, or is that too much? Or should you do more frequent screenings for those who have histories that puts them at risk for IPV, whether it's substance abuse disorder, past IPV, or a clinical suspicion of IPV or depression? So, more tips for the screeners is make notes of anything that's distressing the patient encounters to reflect on and discuss. Use your, after come back to your clinic folks, debrief with the rest of your partners in this and say, okay, this didn't quite work so well. What can we do better? Or this was distressing for the patient. How can we make this better? Contacting making sure that we are the personnel that screen are people that understand that screening protocols, and then making a plan to really address vicarious trauma action plan. Can you assess your own symptoms and risk factors and refer to vicarious trauma for clinicians for that? There's a model for guidance for that. So this brings me to cues, which is something we discovered and it's through Futures Without Violence, and a wonderful organization that deals with trauma-informed care. Cues, they have a training about this, but Q stands for confidentiality, universal education, empowerment, and support. When they looked at survivors that said to what they want the health providers, and this is important, to not be judgmental, to listen, offer information and support, and not push for disclosure. So the patient's ready when they're ready. So universal education, this was eye-opening for us. It was like, this makes all the difference in the world. And this is separate from screening. This is actually providing an opportunity for clients to make that connection between violence, health problems, and risk behaviors, that this all impacts their healthcare. Because I think sometimes our patients don't understand that all of these violent, this impacts what happens in their health care and in their health survival. So if you currently have an IPV screening part of the practice, this is really recommended to do education first. And Qs, or Futures Without Violence, will give you the things you need for free. So they have these cards that are available And you can see, there's a picture here somewhere, um, where you can actually hand these out to patients, maybe just review them. Maybe this can be somebody at the registrar who just reviews. We want to give you these cards. I just want, we give these to everybody. We're not signaling you out. Um, and before we get, if you decide you want to share something with us, understand that, whatever you tell us today, is confidential. Making sure that, again, that you understand your state's reporting requirements and always see the patients alone for that part of the visit. And I'm going to, then this can be tricky. So some often women who are in violent situations or have intimate partner violence, their partners are hovering. They come with them to the clinic. So sometimes this can be a little bit tricky to get them separated so that they can talk with you. So universal education empowerment. So these are, oh, I'm sorry, that's where the cards are. So these cards are available free. There are posters that are available free, and there's a training available. So, for example, I'm giving two of these cards to all my patients. They talk about relationships, how they affect our health. Take a look. And I've also included one for a friend or family member. On the back of the card, there are resources. You can call or text. You can always talk to me. So it sort of opens that door for a conversation with our clients before you even start doing the screening. And it also helps that it's universal. So you're not signaling anybody out. That's the importance of I'm giving this to all of my patients. Support. Thank you for sharing this with me. That is so important. You really want to validate something that when they disclose to you. Thank you for sharing this with me. I'm sorry this is happening. Um, what you're telling me makes me worried about your safety and your health care. A lot of my patients experience things like this. So they don't feel so, this helps patients not feel isolated. Um, from there, um, if they are ready for referrals, how do you make, helping, this is when putting your system in place is important, making sure that you have those warm referrals to whatever you have available locally, for both domestic and sexual violence, or hotlines or apps. And I'll talk a little bit more about some of those things that are available. So I'm sorry, this is such a terrible picture, but I love this. This is in the OB clinic. So often during OB visits, the partner is there. So this is a brilliant idea, where when the women go in to leave their urine, because they always do when they're pregnant, right? It's the ladies' room. The guys can't go in there. And it's clearly says if you are experiencing intimate partner violence, write your initials in red, and the nurse will find a way to get you alone and have, find a way to excuse your partner, and we can do that, in clinic and say, oh, we ask everybody to leave for this segment of the interview. Would you mind stepping out? Et cetera, et cetera, et cetera. And then really then being able to engage, or at the very least, the woman will understand that that we are there for them, even if when their partner is around. So I just loved this idea. All right, so your patient screen's positive. So this was a little flow chart that we came up with on what to do. So it's simplistic. We have a much more vigorous protocol in place, but it clearly says so you provide the counseling, so they screen positive, you provide counseling, you do a needs assessment and determine acuity. And determining acuity is really bad. If it's an emergency situation, um, that's one of the other things that we worked on very carefully was what do we do in an emergency situation where we have to go from that point on because we are concerned about the safety of our client. Does the client desire intervention? A lot of times they're going to say no, and that's okay. They're not ready, but you can start to give them resources. You can start to tell them where to look. Um, that I'm going to talk more about this my plan app because it's amazing. For particularly for those who are technologically savvy. Um, Give them phone numbers or let them, know how to access those phone numbers, and maybe they can start doing some research on their own. If they say yes, is the patient able to discuss a safety plan? Are they ready to do a safety plan? No. Schedule a follow up. Have them come back, and spend, you know, carve out a time where you can actually talk about a safety plan. If they are ready to proceed, does the patient want to engage in the safety plan? No. Again, give them resources they need. Yes, complete a safety plan. Okay, and some of those considerations of the safety plan are listed here. I'm going to talk about safety plans a little bit more in the next slide. So, again, positive screen. You're validating their response. I'm sorry this happened to you. Evaluate. Is the patient currently in danger? Has the assault happened recently? Does the patient want a forensics exam? And being a GYN provider, I can tell you most of the time the answer is no. But when somebody comes to me after they've been raped, I always offer this as as part of assessment for rape. Does the patient have acute injuries that need medical attention? So, were they beaten up? Do they, visibly bruised? Do we need to make special accommodations for that patient to make them feel safe? Does the patient wish today to speak to a domestic violence advocate? Educate the patient about the level of risk as they move forward. If they're not HIV infected, the risk of HIV, the risk of other STDs, and other special accommodations. Make referrals, and then make sure you chart it in the record that they had a positive screen. If they're not ready to deal with this, you can resume the patient visit, but understand that you now opened, you're sort of re-traumatizing people. Are they okay to proceed today with their visit? And so it's just a question you want to make sure that they may not at that point want to, to have their clinic visit at that point. So for safety planning itself, so some of the consideration, if the patient is comfortable with the screener, will the screener be doing that safety planning, or do we have to refer them to somebody else? Are they technologically literate? Do they have access to a phone, to the internet? Are they able to use apps? Is there a language barrier? Many of our patients don't speak English. How do we help them if there's a language barrier? And what do we have available in the community for those who don't speak English? Are they visually impaired? Are they ready to act? Do they want help now, or do they want to defer help? Do they just want information today? Would they like us to assist them with planning? This all should be done now in a safe space in the clinic that's quiet and calm. So, some of the aspects of a safety plan would include patients when they need to call for help. Do they have code words? When I'm with my partner, what's my code word? For my children, do I have a code word? When I need support, I can turn to these people. Having, sort of thinking through the different aspects of a safety plan, whether they're at home or in school, or if they're stranded and need a ride, who can they call? If I decide to end my relationship, what do I do? How do I provide childcare when I'm ready? If I need a safe place to go when I don't want to be at home, where can I go? If I have to leave my home quickly, how do I do that? Where do I go? If I end my relationship, I'll do it they have them think about when is the best time for them to do that. If my child is in danger, I can tell them to go to a certain place. what is my nearest police station? When I go out, I'll let you know where I'm going. So talk, making sure that somebody knows where they are, that they feel safe with. What to do to avoid my partner, whether at work or other places. And the last one is, do they have a safe place to put a ready to go bag? So, for those who are really considering leaving their partners and as part of their safety plan, having a I have to leave right now kind of bag with things that they need or things that maybe their children need, but do they have a safe place to keep it? So here are some of the resources that we have available in Maryland and nationally that I can share with you for those of you who live in Maryland. These are incredible resources. I already talked about Futures Without Violence. Um, there's the Maryland Healthcare Coalition, the Maryland Network Against Domestic Violence. You can start looking online for other resources and see what works for you and your community. Trainings, the Q's that I talked about briefly earlier has a training that our group is going to be doing shortly, so I can't speak to it yet. But really using that evidence-based intervention to address domestic and sexual violence and advocating universal screening. And mental health first aid, which is provided in Maryland that we just completed, and I can't speak highly enough about it. It was a wonderful, wonderful training, and it's not that everybody in your agency has to go. So it's a train the trainer sort of thing. So you only need like one person in your agency to complete the training, and then bring it back to you and do the training for your agency. So it really was incredible, and I can't advocate enough for it. This is what the website for Futures Without Violence looks like. And this is the homepage for the Mental Health First Aid of Maryland, their training course. So I put the website on the bottom here. So if anybody's interested in looking into it. So my plan is an app that was developed at Hopkins and was validated first overseas in Africa, and then brought back, and then brought back to the United States and up and that different plan, obviously, different app for the United States and validated here. And it is incredible. It really will, patients can actually self screen with this app, decide, see what level are they in danger, what are their strategies. It really walks them through the whole process on their own. So I have this on my phone so I could show patients. It's You can find it at the app right there. It's called My Plan Safety App. That's what it looks like, and this is the icon that shows up on the phone. So again, this is an incredible tool, particularly for those who are comfortable using apps. So I talked about collaborations earlier. So we're lucky at Hopkins because we have lots of people we can collaborate with. And this is actually a study that Dr. Jones and Nancy Glass are involved in, looking at a community bridge to care initiative for trauma and violence informed care for women survivors of intimate partner violence and living with HIV. So we're going to actually be able to sort of validate the work that we do as we move forward and implement our strategies and see what works and what doesn't work. And that's part of the study that they're doing. So again, it's looking at, understanding that health providers can identify multiple complex unmet health and social issues daily. What do when we've all dealt with this: intimate partner violence, housing instability, food insecurity that negatively impacts the health of our patients in their care. And we know right now, as of Saturday, a lot of our patients are going to be losing their SNAP benefits. So food has become it's increasingly becoming more and more important, as is housing. Um, what are the community-led organizations that have this expertise that we can utilize and help our patients access? And then really building and strengthening those bridges from the healthcare provider to the community partners, which I talked about already today, and really knowing who those partners are in your community, and maybe going there and introducing yourself, and getting a face to face and seeing what their organizations look like would really help with those warm handoffs. So these are just the study aims. I'm just pointing them out because I'm really happy that we're going to be able to really assess what we're doing in our clinic. And you can see that it includes the My Plan app as one of the interventions of the study aims. And so I'm really excited to start implementing that as well as the intervention as it's part of the study. So I just want to do a shout. I think we have time for questions. Oh, good. A shout out to our team, particularly Joyce Jones, who really has led the charge for this. And we've all hung in there with her, this group of mixed providers, nurses. I'm not a PC, I'm a PAC, a PA. Sorry, I screwed up my own title. And Thomas and Allison are social workers and part of the clinic staff in the Bartlett Clinic. Allison is a nurse that works with me. Both Sheila and Leanne are part of the staff in the Bartlett Clinic. So really, we've crossed sort of departmental silos to do this work. So that's it. Thank you for your time. I guess I need to stop sharing, right, guys? How do I do that? See here. Oh, here we
I
go.
took care of it, Jean.
Oh, you
was
are so wonderful. Thank you.
that was great, Jean. That was really good. Of course, know a lot about what you're doing, but it's
Yeah,
nice to see it put all
yeah,
together and to
yeah.
see where it's headed. So
Of course,
great
the
job
hardest
and great
part was
talk.
taking 2 years of stuff and
Yeah.
trying to condense it.
Yeah, no, fantastic job. There's already a question in the chat, and as I said earlier, if people have a question, just raise your hand or unmute and ask it. But I'll start with Valley
Did
Meeks.
you freeze? I think you
Is there
froze.
any data on
You
same-sex intimate
froze.
partner violence? For example, why am I frozen?
Yeah, you're okay now.
Am I
Yes.
frozen?
So yes. So I think there's less
Okay.
information. Oh, I think there's less information on that. But if you want to send me your information, I can look it up for you. I wasn't ignoring we're starting with women right now, but we also understand that we have different populations that might have different needs. That's going to be sort of like phase two for us, including the LGBTQT. Did I say that right? Did I get my initials mixed up? And also youth, and also people who are non-English speaking folks. So I don't have the data on the tip of my fingers about same-sex partners.
The other part to I think it's a really interesting question because to be the suggestion about the red versus the black marker was really I love that. And
Oh,
in same gender violent situations, we may need to be more creative. And if people have
yes,
ideas of how to do that, would love to
yes,
hear what people have done. Certainly we see I see a lot of young MSM, and oftentimes they're with an older partner that's doing the
mm-hmm,
same sort of hovering, and you're trying to do the wink and trying to see if they're okay. And sometimes I feel like
right,
we get it right, and sometimes we don't. Or women abusing males. Like there's all of those dynamics, and I think are in a very heteronormative male is the abuser society. We oftentimes miss that. So I want to make sure we're thinking about all the different scenarios. But I think starting here was a great start.
yeah. It's in an OB clinic because we always collect urine. That was a
Mhm.
perfect, way to find out if a woman needed our assistance. So in GYN sometimes, so often if there's a partner available, of partners in the room. Sometimes we've gotten into the habit, particularly if you're suspicious, of just saying, okay, this is, I ask everybody who comes to the clinic to just I need a couple of minutes alone with so and so, and hopefully they'll step out. That doesn't always happen, but hopefully they'll step out and allow you to do that. If they give you a hard time, just leave it be. But at least the patient knows that that you're there for them if they want to reach out to you at another time. Yes, we can share the slides. I just saw that pop up. Absolutely. Yeah.
Raising his hand with the
I- will
question.
send them to I'll send them to you guys and then you can
We'll
send
share.
them out.
Yeah. If you
Yeah.
attended, we will definitely share. Keith Booth, go ahead and unmute and ask your question.
Oh, she just answered it.
Oh, that was the
Yeah, it was in
oh,
I saw it pop
it was
up.
the same question in
Yeah.
the chat. So you were
I
you were
was asking
speaking.
about the
Yeah.
slides because you showed one of the resources, but it was kind of moving along and I didn't get there.
Yeah. Yeah, no,
Mhm.
absolutely. Yeah. It's and there's so much out there. And as I said, what works for us may not work for your institution, but just to get started, I think the important thing is to just start the discussion in your clinic, in your healthcare center. And that's how it began with us. It started because we did this SAVA study and we realized, wow, this is a big issue. This is, and we were all a little bit afraid of IPV, and not because we were afraid to ask, but we didn't know what to do. We didn't know how to help people. And we didn't want to traumatize women or men and then, screen positive and say, oh, I'm sorry to hear that. Goodbye. You're really having something in place.
I also like that you talked about the different kinds of domestic violence because I think we see a lot of economic disparities and we're about to
Yes,
go into, well, we're in the middle of a shutdown and with all of that, and
it's going
that's
to be
only going to
bad.
be exacerbated. I
Right.
think pregnancy is a time where that's exacerbated. There's certain,
Right.
right? So COVID exacerbated, and so
Right.
being sensitive to
Right.
that. And I love that you
HIV
ate
increase. Right.
diagnose 100%. And so
Right.
I think the idea of being afraid to ask because we don't have anything to do about it doesn't, I think, take the responsibility away from us from
No, it does
asking,
not.
right?
It does not. Right. It does not. Right. So yeah, that's why we spent a lot of time really, working this through, so that we can really be there.
Yeah. I think
Yeah.
one of the things that you talked about that I'd love to hear if there are people from other locales on the call, knowing what your resources are. And we in at Hopkins, we get referrals from people come from everywhere, from all around the
Everywhere.
state. And
Right.
sometimes it's a little bit harder if someone's from Harford County. Well, what are
That's
the
right.
resources there? And so would
Right.
love people to if you have any, raise your hand so we know who
Share.
to to share so we can connect with.
Absolutely. Yeah.
Because even if we may see it online, we may not know some of the nuances about what is desirable or not, or what may be challenged. So, would love to hear from you if you have resources in your areas to share
Partic-
with
Particularly
us.
the rural areas.
Definitely,
Yeah. You
definitely,
know, yeah.
yeah. Okay.
We're Baltimore City, we are lucky because there are tons of resources.
So
But
Michelle Buranin, I hope I said that
mhm,
right, is saying in Harford County has the Sexual Assault Spouse Abuse Center. Um,
wonderful.
so I don't know if
Yeah.
that's something that's in each county. I think that's very helpful, and please, others feel free to drop it in. Any other questions? I had one. I don't like to monopolize, but I did have one. Um, I think for me, what the question that it sparked when you had that algorithm, and I'd love for you to, when we share the slides, you'll have that. But when you had a scenario where the answer is yes, and it's imminent, not safe now, and just wondering if you've had a chance to test that worst case scenario and how'd that go?
We
And
we we haven't tested it yet because but we have worked specifically on that, and
mm-hmm,
I can as we put that in place, I'm happy to share that with people on how we're going to
mm-hmm,
do it because you know uh, or if somebody's suicidal at that,
yeah,
suicidal, or how do we put that into place? So that was one of the things we talked about, and so we have what we call we have we have there are people in the clinic who we have identified who are can be available for when that happens. So
mm-hmm,
I'm one when I'm there. Some of the nurses. So
right,
really identifying people who will then say, "I'm here. Let me take this. person now and help them through
Right.
this
Like the
process.
bat scenario, basically.
Yeah, right.
And then the last, we probably have some of my team members on the call. There are times when the person's identified and there's nothing to do about it. We had a scenario this week where there was a young woman. We were concerned there was an IPV. She texted almost like a code word, I need safe place now, and then didn't respond when we were trying to get back. And so an hour went by. And so ultimately, we had to make the call. Are we going to make a call for the police or something? I'm just curious in what you're doing. Was that the right move? And we think so, but we'd love to hear your thoughts about
I
that.
think so, yes, because that's
Yeah.
frightening. And
Yeah.
she already reached out to you,
She
so
did.
she wanted help. I think not the yeah, yeah. So I think reaching out to the police would be worse. What if something
Yeah.
happened? What if there was
Yeah.
something, yeah,
Yeah. It's just,
you don't have any choice.
in many of the communities that we take care of, sometimes police being involved can be another issue. So there was a lot of angst on the
It's
team, but
tough. Yeah,
yeah. Yeah.
that's a tough one. Yeah, because you can't physically go there. That's not
No,
gonna
no, no,
work.
no.
Yeah,
They
so
entertained it for about 2 seconds.
really
I
the
said, no
only
way.
option. But hopefully though, if you can, give the police when you call them, you give them a heads up so that
Yeah,
maybe they're prepared. And I don't know, I'm hoping that more and more that police departments involve social workers with
correct.
these
Kind of like
sorts
with
of
mental
calls.
health
Yeah,
issues, right? If
yeah,
there's, yeah,
yeah.
yeah. Okay. All right. Last call for questions. Jean, that was fantastic. Thank you for not just a great talk, but for what you guys are doing and for taking this issue head on. Really appreciate you taking the time to share with us today.
Absolutely, my pleasure. And I will send you those slides.
And we'll
Thanks,
receive
Jennifer. I
them.
saw Jennifer's little heart.
Yeah, no, lots of kudos in the chat and requests for the
I hope I didn't
slides.
talk too fast. I'm from New York and I tend to like talk fast. So
No, no, that was great. Look, I'm Caribbean, so I talk even
you
faster. So
too,
we're
right?
we are a duo, and it is a tough topic. Thank you, Jean. Really appreciate. Thank you, everybody. And we'll see you
Absolutely.
next time when it is going to be Ronald Meeks doing part two. And many of you attended the conversation on basically ACEs, and so it's going to be him
Yeah.
doing and what next, essentially
And what
after
next?
yeah, and what
Great.
next, because we were left with, well, we all have ACEs, and then what do you do, and how do you target resources and think through things? And so he was, uh, nice enough to say he was going to come back, and he was excited and anticipating that. So that's going to be on the 20th, right before we go out for Thanksgiving. All right.
Great.
Thank you,
All right.
everybody.
Bye,
Thanks again,
everybody.
Jean. Talk to everybody later. Take care.